so the next speaker is Dr. Richard Wu. He is a clinical assistant professor at the Ohio State University Comprehensive Cancer Center. He received his MD from the University of Texas McGovern Medical School at Houston and his PhD from University of Texas MD Anderson Cancer Center as part of the NIH-funded Medical Scientist Training Program, or the MSTP. He had completed his oncology fellowship training at the University of Pittsburgh as a faculty in cutaneous oncology at the OSU CCC. He is currently the PI on 4 ongoing phase 1 and 2 studies, including his investigator initiative study on the use of neoadjuvant TIL, which he will talk a little bit more today, for stage 3 and 4 melanoma patients. His research work in collaboration with his colleagues has been published in prestigious journals such as Clinical Cancer Research, Lancet, and New England Journal of Medicine. He has presented his research at national, international meetings such as Society of Immunology and Cancer, American Society for Clinical Oncology, and the Melanoma Research Foundation. And today he is going to go over the TIL. Okay. You want this in slide mode? Yeah. There you go.
All right.
Yeah. Watch the sharing. Okay.
All right. Are we all ready for this? All right. So thanks for the invitation from MRF and my colleagues here to for me to spend this next hour with you talking about TIL therapy. Again, this is an area that I've been involved of. And actually, I started doing laboratory research on this like about 2 decades ago, and I've seen therapy going through like trials and tribulations as it goes through the different phase of clinical trial until its recent FDA approval. So of course this is a very this is an area of of particular interest to me. And this is my online therapies. So I'm going to talk about like the biologic principles behind the TIL therapy, like why we think that it works well for the melanoma patients. And I'll show some examples of clinical responses that we have seen, in patients with the, to the TIL therapies. And I also briefly talk about this comparison with the ipilimumab, which is another immune checkpoint therapy that I think most of you are probably aware, know it by now from the talk earlier today, and how it compares against TIL in the patient that have failed the anti-PD-1 immunotherapy. And I also spent some time talking about what these T cells and TILs are fighting against, like how well that they can recognize the targets on the melanoma cells. And then I'll talk about some of the laboratory research work that I've done on TIL to try to tease out like what kind of what subset of immune cells are responsible for that immune for the response to what subsets are critical for response to the TIL therapy, and also which particular type of CDAs that we have found to have correlated with patients' immune response. And also I will and then if I have more time again, then I can talk about like some of the future sort of next generation TIL therapy that's in development. So TIL therapy was it was developed by a really brilliant physician scientist at the National Cancer Institute. Actually, he's right now he's the chief of surgical branch over there. Is Dr. C. Rosenberg. I'll show his picture up there over there. And so the idea behind TIL therapy is that that oftentimes when if you were to take a melanoma tumor out from patients, they are often infiltrated with tons of T cells. But we know that even though that this is a very immunogenic kind of tumor, it attracts the attention from the immune system. There's still in some patients these tumors just don't shrink, right? And I think the part reason is because you're not getting enough of those T cells, right? So when you have like millions of tumor cells and you probably need 10 times as much T cell to be able to like to shrink it. So that's really the main idea behind the TIL therapy is it's based on this idea that what happens if we just take out a piece of a patient tumor and isolate the immune cell inside of it, the T cells, and then put it through a very strong stimulation process in laboratory to turn them into billions of cells. and then refuse back into the patient so that they will have a lot of these T cells that recognize the tumor already to fight against the cancer, right? So instead of a instead of like million tumor cells with million T cells, now you have like million tumor cells against billions of T cells. And I think that's really the idea behind TIL therapy, is that what happens if we expand to this huge army of cells to fight against this, the cancer. And as you can see here, that the process, it's not, it's pretty, it's logistically intensive, involves a surgery where the surgeons have to look at, has to identify an area of tumor that's at least like 1.5 centimeter in size. That's what the Iovance TIL platform. And then and they have the surgeon take it out and then and send to a sort of what I call the bioreactor facility, where they actually cut this into pieces and they put them in this bioreactor to grow out these T cells with a very strong stimulation with IL-2 and anti-T cell receptor antibody. And then also, so by the end of this process, which usually takes about 22 days on average, you're going to have like around like 1,000 to 2,000 fold expansion of the T cells that you start out with. So essentially, you end up with billions of them. And then, and after this patient have this TIL product that's generated, they'll then be admitted to a hospital where they go through about 5 days of chemotherapy with the 2 different chemotherapy drugs to kind of deplete out their immune system. And the idea is that is to eliminate the competition between our existing immune cells with the TIL, right? Because these TILs, they need access to space and nutrients. So if you have too many immune cells that's crowding out, they might not be able to persist. So that's the idea behind that chemotherapy. I mean, we call this a lymphodepletion. And so patient that will get 5 days of chemotherapy, and at the end of that, they will when their immune systems are pretty much depleted, then they will get infusion of a TIL therapy, followed by this drug called IL-2, which is a T cell growth factor to kind of help these cells expand inside patient's body and help them persist. So this is a picture that Dr. Steve Rosenberg likes to show when he presents the TIL therapy at scientific conferences, right? He has some patients that had a very impressive amount of tumor burden, and some of them have achieved a pretty impressive response. You can see that this patient has a huge mass on the neck and then went into complete remission after TIL therapy. Yeah, so it took almost 25 years to get to this point of FDA approval. Just goes to show you that the progress in medicine, unfortunately, goes at a very snail pace sometimes. And so this is a pivotal clinical trial that led to the FDA's approval. They basically show that when you give TIL therapies in patients that have already failed drugs like Opdivo or Keytruda, there's about a third of patients that have that can achieve a pretty more than the 50% tumor reduction, and actually more than 30% of tumor reduction. So that's considered. So patients that have a more than 30% reduction, they are considered to have a positive response to the treatment. So about a third of patients can achieve that response after TIL therapy. And they also show that that TIL therapies have also significant impact, especially on the patient survival. If you look at the right side of the curve, so for those patients that have received the TIL therapies, they have a on average around like survival in the middle around 13.9% months, which is around which is over a year. And you got to compare that against like if this TIL therapy were not available, these patients would not have made it within 3 to 6 months. And there's also a very interesting clinical trial that this actually came out from Netherlands and it just got published like in late 2022. And basically this is a so in this trial, the Netherlands hospital actually manufactured their own TIL product. This was not Iovance TIL, and they basically look at what happened if you randomize patients that have failed the anti-PD-1 immunotherapies to either getting the TIL or or another drug called Yervoy that I think some of you are familiar with. And you can see here that that patients that have received TIL did much better, actually more than twice as good as patient getting the Yervoy. Right. So this is an example of a patient that was treated that was in one of my TIL study. Again, this was in my neoadjuvant TIL study that sponsored by my colleague here from Iovance. And so this patient, I want to show you. This is the pre-treatment on the left-hand side, and this is post-treatment. And I can tell you why she turned that way. So after she got the TIL therapy, the T cell from the TIL generated a very vigorous immune response against not only her tumor but also against the cell that give rise to the melanoma, which is melanocytes. And this is why that you're seeing all this like rashes that she had all throughout her body. And after these cells were getting killed, that's why she ended up with completely white hair, because she lost all her most of her melanocytes. And so we actually used one of her lymph nodes that were involved with tumor as the target for making the TIL products. And you can see here that before treatments, this is where her tumors were. And then after treatments, that lymph nodes have completely disappeared. And I think to this stage, I think she's almost at 2 years of follow-up, and she's still doing really well. Yeah, so it just goes to show you that, of a power of this type of therapy. So so actually before I came to Ohio State, I did my PhD at MD Anderson, and the project that I work on, it was really it was highly translational. It's about at the time they just started this phase 2 TIL trial. This is before all the immunotherapies were available at the time, and actually this is this is even before the era that people believe I mean actually at the time there was a lot of doubts about doing immunotherapy at the time. So that was kind of environment that kind of that had when I started this work. So at the time we didn't really know like what type of immune cells were responsible for the response that can correlate to response in patient getting a TIL therapy. And at the time, my PhD mentor actually, was started focus on this type of T cell. It's called CD8 T cells. So there's two type of T cells that we have in TIL. So there's a CD8 T cell, which are what we call the killer T cells. These are cells that's directly responsible for killing like virus infected cells or tumors directly. And CD4s are basically the cells that that sort of help the CD8 to be able to kind of do their job. So so they don't necessarily directly kill the cancer cell, but they sort of help the CD8 do their job. So at the time, we didn't really know like which ones were responsible for the response. And turns out that at the time there was some really interesting molecular tools that we can use to really to kind of help identify how what these T cells are reacting to. This is technology called MHC tetramer, where you can actually load a tumor antigen on a molecule, and then you can sort of have you can actually stain that with the with the patient's TIL and kind of see how they're reacting to. So this is experiment that we did actually early on, that we have shown that that some of these CD8s are actually they can actually recognize these tumor antigens. So the classic tumor antigens are like MAR1, GP100. These are tumor antigens that are both expressing both normal and tumor cells, but they're expressing higher amount in the tumor cells. And we can and we show that in fact these CD8 cells can actually recognize those tumor antigens. And more recently, now we have more powerful molecular tools that we can sequence patients' genome in it used to take like months to years, and now we can do that in like weeks. Okay, and I think with that technology, that's called next-gen sequencing or parallel sequencing. Now we can actually figure out that every patient's mutation within within a week. So with this technology, we're able to show that that we can identify the mutations that's present in each tumor from each patient. So this is a very personalized sort of a mutation profile. And then so what happens in our bodies then we have cells that can take a fragment of those mutations and kind of present on the surface. And so here we show that the TILs actually can recognize these unique mutations that arise from each patient. So this is a very sort what I call the very personalized type of immunotherapy. Yeah, so this is my simple diagram to kind of show you why I think TIL is different from the therapies that kind of come before it. It's able to recognize different categories of antigens, right? I mean, it can recognize these overexpressed antigens, that it's not necessarily the best because they're also expressed on normal cells. So it's possible that they can cause some damage. With you can kill tumor cells, but also can damage the normal cells too. But they can also recognize a different type of antigen that I just mentioned, which is the antigens that arise from each patient's unique sort of mutations that happens within their tumor. Yeah, and then so this is kind of looking back to the time when I was at MD Anderson, where when we were doing these TIL studies, and then these were some of our clinical trial results at the time. We showed that again, this is a small number of patients that that at least when we did this trial at the time, we showed that around half of the patients actually, end up responding to treatments, and some of the responders, survive for more than 2 years. So back to the lab. So now we have all this, great data showing that TIL, doesn't work for everybody, but works for a fair number of patients. So we kind of take this information back to lab to kind of see like how we can really figure out like, what would help distinguish between responder and non, like what markers on these T cells can help us determine responder and non-responders. And of course, the first aspect that we look at is the difference between CD8 and CD4. So we have shown here that this is all published data too. That CD8 is very critical. So patients that have that when they have a lot more CD8 cell products and CD4 in their TIL products, they do much better. Again, this is a correlation, doesn't necessarily imply causation, but this is a correlation that we have seen with this. And this is a plot that we so this is a plot looking at the amount of patient CD8 that patient gets against their degree of tumor shrinkage. And you can see here that when they get more CD8s in their TIL product, they do their tumor shrinks much better. There's a correlation there. And so now we have so now we have figured out that CD8 TIL is very critical. The next question becomes, is there a particular subset of CD8s, any markers on the CD8s that can help us identify responders and that can be associated with a positive response to the TIL therapy. So initially we were looking at these inhibitory receptors. So inhibitory receptors, you might have like like molecules like PD-1, because those are the target that's hit by our immune checkpoint therapies like Opdivo and pembrolizumab. So the idea that we started initially was that if patients still express more of those inhibitory receptors, like the receptor that would inhibit the activity of these T cells, they should do worse. And actually, when we actually try to look at the expression of those receptors on TIL, it turned out to be actually the opposite. So these are kind of like my slide talking about the different inhibitory receptors, right? So we have PD-1, that's a drug target for a lot of the immune checkpoint therapy that we use, and CTLA-4, which is targeted by the Yervoy or ipilimumab. And there's also this other this inhibitor receptor that we don't know very much about until it's called BTLA or B and T lymphocyte attenuator. Again, these receptors, they all function to dampen the T cells activity. So initially we started thinking that if patients CD8 TIL, if they have expressed more of the molecule, they should do worse. But actually it turned out to be the complete opposite. We found that that in the patient's TIL product, if they have CD8s that express more of this, particularly this molecule called the BTLA, if they have the CD8 that express more of the molecule, they actually end up doing better. And there's also a similar trend with PD-1 and this other molecule called TIM3, but the association was the strongest with the patients getting the CD8 cell expressing BTLA molecule on their surface. So then the next step is to kind of separate these cells out into different populations, with the molecular techniques that we have, to really study them in depth. So we have this technique, it's called the flow cytometry, that we can actually sort out this different T cell population in a lab to kind of study their differences. And again, just functionally, we found that patients, the CD8 BTLA positive TILs, they're much more proliferative in response to IL-2 or T cell receptor stimulation. And we look when we look at the differences of their of this T cell subset in terms of their gene expression profile, we found that the patients TIL that express BTLA actually have a much sort of a younger, like less differentiated sort of phenotype. So T cell just they age just like humans. I mean, as we put it through the process making TIL, these T cells do gradually age, right? And so I think the key finding from this study is that and that is an experiment that we did where we actually track using a different technology to to track these BTLA positive negative CD8 TILs after they're infused into patients, and we show that patient gets more of the CD8 positive BTLA positive TILs. These cells tend to kind of persist for a much longer period of time than the other subset. So I think what this research is telling us is that that for TIL therapy, it's really important not only to get the CD8, but also you have to get these CD8 cells that are younger, like less age and less differentiated cells. And that's important because then these cells are able to proliferate better. They're able to persist, longer once they're infused into the patients. And we also learned that that these inhibitor receptors, they don't necessarily, they have to be kind of interpreted in the biologic, in the appropriate biologic context. Like just because they express and doesn't mean that these cells are exhausted. And we also have some data to show that that this BTL molecule not only is a marker for a younger sort of a TIL cells, but at the same time we also show that that it's involved in kind of in some signaling sort of event to keep to keep these cells alive once they're infused into a patient. And that's the data that we have included in the in our publication later on. So I think that I think for the next part of my talk, I'm gonna discuss like what's the future landscape for TIL therapy, right? I think there's a lot of excitement. I think my view is that with Alvan's Entecavir, that's the trade name from their TIL product. This is a first generation product, right? This is the first first of its kind therapy, but this is still at the very beginning, the tip of the iceberg. I mean, there's still ways I think that we can make the TIL therapy better in the future. And one of the approach that Alvan's is doing is to so one approach that Alvan's is doing is that instead of giving patients like drugs like Opdivo or Keytruda, why don't we combine them directly with TIL? So the idea is that as I showed before, the TILs, they have T cells that can recognize each patient's mutations and or some of these like overexpressed antigens. So adding drugs like Opdivo and Keytruda can essentially help to liberate these TILs from being inhibited by tumors. So that's really the idea of combining these two types of treatments. So in the trial, they're targeted toward those patients that are treatment naive. It means that they haven't been treated previously, so they're newly diagnosed stage 4 melanoma. And the data that was presented was pretty impressive. I think they show that more than around 65% of patients were able to see like tumor shrinkage more than 30%. And so just to put this in perspective, the best that we can achieve with drugs like Opdivo, Keytruda, or even Opdivo Yervoy combination is around 50%. So about half of patients will not do well with those treatments. This to me is probably the first therapy the first therapy approach that I know of that can sort of hit that's breaking that 50% barrier. So I think this is a trial that I think it's in the later stage of a it's a phase 3 study in the later stage of development. So really looking forward to this combination going being a possibility in the future. And another company has developed like a different sort of TIL product. It's called the OBX-115. So the reason for this development is because the IL-2 that's used in TIL is a very it's not an easy to tolerate sort of a drug. This is part of the reason that right now to give the TIL therapy, we had to have like an ICU level facility to be able to handle complications from the treatment. So that was the idea of developing this different type of TIL therapy where instead of using IL-2, the company actually engineered these T cells to only express the different immune molecule called IL-15 when there's a separate sort of a harmless drug given to the patients. So that drug will induce IL-15 to express on these TIL cells membrane to be able to sustain in itself. So they're able to completely avoid the use of IL-2, and the hope is that this can increase the number of patients that can be that we can consider for the TIL therapy. And I think in the again, this drug is still at a very early stage of development. It's still in phase 1 studies. They have treated around 6 patients, I think, with the full dose, and they're able to see about objective response in about half of the patients. So this is another really promising therapy that I think it's worth paying attention to in the next few years. And I want to sort of end my talk with this really interesting concept that actually so it turns out that the T cell, they have a repertoire of inhibitory and activating receptors. And so my colleague at Bristol Myers Squibb, they developed this drug many years ago that that can strongly activate the activating receptor itself. So the idea is that that this will make the T cell a lot more active, right? So when they took it to a clinical trial, unfortunately, when they, if you were to give this drug directly to patients, it actually causes a lot of, it actually causes the immune system to overreact. And some of these patients have died from liver failure. So because of that reason, the BMS actually withdrew this drug for development for a very long time. So then when I was at MD Anderson, my PhD advisor at the time, was thinking that, if this drug is so toxic to give directly to patients, what happens if we give, if we give this to, what happens if we use this drug during the time that we're growing TIL outside the patient's body? And what we found here is that as I mentioned before, the CD8 to CD4 ratio is very critical for the response to TIL therapy. And I think we're able to show that if you were to add this antibody during the time that you're growing the TIL outside the, in a laboratory, it's able to alter that CD8 to CD4 ratio. It's able to significantly increase more CD8 than CD4. And we also show that the CD8 that we generated can recognize these unique mutations from each patient. And actually, I think it took almost probably decades or more to convince Bristol Myers Squibb to allow us to, allow my former colleagues at MD Anderson to take this concept into clinical trial. So actually now they're doing this clinical trial for the uveal melanoma of using this anti-BB, 4-1BB stimulated TIL and give this type of TIL to patients with eye melanoma. Anyway, so I just want to acknowledge my my colleagues at OSU who have been really, especially play a very critical role in immune cancer sort of getting, my TIL trial up and running here. And also some of my former colleagues at MD Anderson that have really jump-started my career and also lifelong interest in TIL therapy. So we hope that this is going to be available. I mean, I think we're still at the very tip of the iceberg in terms of the TIL therapy, and I think we, there's a lot of excitement. I think in the future, in terms of what this is going to turn out to be.
Anybody have any questions? Dr. Wu, while you're up there, I know you don't have the slide for it, but Dr. Sebula had mentioned about benefits for eye melanoma. So did Dr. Contreras. Yeah, Contreras. So can you say a little bit about tebentafusp treatment for metastatic eye melanoma?
Yeah, so tebentafusp, this is something separate from TIL. This is not TIL therapy. Okay, this is a type of a bispecific antibody, and it's a special engineer. So it has two business ends. So on one end, it's, it will bind to a tumor antigen that's expressed. It's called GP100. That's one of the antigen that I showed earlier, right? It's something that's overexpressed by the melanoma tumor cells. And on the other end, it binds to the tumor cancer-fighting T cells. So the idea is that by giving this drug, then you will bring the T cells in close proximity to a tumor, so that will allow your immune cell to directly to kill the cancer off. And also it also helps that because I mean the amount of T cell that can recognize the tumor antigen specifically in each patient is a very small amount of T cell, right? So by giving this drug, you can actually redirect most of your T cells toward the cancer cell, even though this T cell may not necessarily recognize the tumor directly. So this drug is officially, right now it's officially FDA approved for the eye melanoma currently, but there's also ongoing clinical trial in looking at this for the other type of melanoma as well. And actually my colleague at Pittsburgh is doing that clinical trial, in using this drug for the patient with the skin melanoma. So I think the excitement is that for uveal melanoma, this is really the first FDA approved therapies that have been shown to have impact on patient survival. It's able to make patients live longer. And there's no other therapy that came before that were able to do that. Right. So the main limitation is that that for patient to qualify for these therapies, they had to have this molecule in their cell called the HA2. Right. That's something we call the tissue type. And so tissue type, it's something, it's kind of, it's more known in the world of organ transplantation, right? So each patient, like you get half of your tissue type from one of your parents, and then and I think so someone needs organ transplant, you have to kind of try to match it to a donor so that your immune system won't reject it as foreign. That's kind of how I understand tissue type to be. So in the context of a tebentafusp, you have to have this particular molecule called A2, because then this will allow your your cells to present antigen that can be recognized by the drug. Otherwise, if you don't have this A2 molecule, the drug won't even bind to anything. Right. And again, this drug is given once weekly. I think some of you that have getting treatment for, from me probably knows like how like cumbersome it is, right? It's a weekly treatment that goes on indefinitely as long as you're benefiting from it. And I think the company that's developing the drug is they're trying to develop like new drug that can make it last longer, so you can give every 2 weeks instead of every week. And also there's a lot of there's also like ongoing effort to try to see if we can use this in different patients, because the reason that the company selects the A2 patient is because it's the most common sort of a type of molecule in the Caucasian patient population. So around 40% of the Caucasian patients will have this molecule. But in my clinics, I do have my fair number of patients that do not have that molecule, and couldn't qualify for the drug. So we still need so there's an ongoing effort to try to see if we can use this drug in more patients in the future. Yeah.
The IL-2 component of, so is this IL-15 or whatever? Is that going? You see that replacing the IL-2, or is that additional?
Yeah. So yeah. I mean, we can go into more details about this, of course. So the reason IL-2 is so like hard to tolerate is because so there's different IL-2 receptors. There's IL-2 alpha, beta, and gamma, right? The one that's responsible for most of IL-2 induced side effect is IL-2 alpha receptor. So what happens is that when your body exposed to IL-2 and binds to IL-2 alpha receptor, it causes something called a vascular leakage syndrome. It just literally means that you're leaking fluid from everywhere, from your blood vessels, from your organs, whatever. And that's why some patients can get pretty sick, because then they can drop their blood pressure and end up in ICU, right? So with IL-15, the IL-15 actually only affects the beta and gamma receptor and spares alpha receptor. So then you're able to have most of the therapeutic benefits of IL-2, but without its toxicity. That's really the idea of behind using IL-15. Yeah.
Any other questions? Good. Thank you, Dr. Wu.
All right.